Hi everyone, welcome to Endocast. I am Dr. Tuğçe Apaydın. Today we are recording live from the second day of Endobridge 2024. Just moments ago, I have attended a fascinating presentation by Dr. Nicola Napoli titled Bone Sweet Bone. Right now, I am with Dr. Napoli. Thank you for joining us today.
Hello, everybody. I am Nicola Napoli, and I'm pleased to be here today. And today we discuss the risk of fracture in people with obesity and diabetes. And I would like to remind you that there is a higher risk of fracture in people with higher BMI. So basically, people with obesity have a 20% higher risk of fractures, but they have also higher risk of falls and low vitamin D. But these people is also insulin resistant, and in general, insulin resistance is associated to increased risk of fracture. But the most important part is that these people usually have a normal or even high BMD. So this is a paradox because people, for example, with type 2 diabetes have a normal BMD, but have a double risk of hip fractures. So it's very important to recognize bone fragility as a complication of diabetes. And the risk factors may be different because a long-term duration of the disease, glucose control that is not good enough. For example, people with A1C more than 8, stable A1C more than 8 is an independent risk for fractures, frequent hypoglycemic events, as well as neuropathy or family history for fractures. So what we should do? People with diabetes should be screened for osteoporosis, doing a bone density test. And I would like to remind you that the threshold for treatment is minus 2.0. But of course, we will start the treatment independent of BMD in case patients have already a fracture, a vertebral fracture or a femur fractures. And when we need to treat, we may use bisphosphonates or we may use denosumab. Although we should be careful with denosumab because some data prove that denosumab is not good for people at high risk of hip fractures. An ideal medication is teriparatide because we have strong data on the efficacy of this medication in people with diabetes. And the reason is very simple. People with diabetes have low bone turnover, means that they have low bone formation, but they have also low bone resorption. This is a condition that is very similar to what happens in people who is treated with bisphosphonates for many years. So if I give teriparatide, there is a slight increase in CTX, meaning an increase in bone resorption, but there is mostly an increase in bone formation. So in this case, I basically enhance the activity of osteoblasts, but also osteoclasts that are needed in people with low bone turnover in order to clear up and to clean up basically all the micro damage, all the damage that has been accumulated in the bone. And finally, I would like to remind you that the bones of people with diabetes has more density, but again is more frail because there is less flexibility. Collagen is harder. So people has maybe normal BMD, but again, please remember that these people are more frail and they have a more risk of bone fragility and to develop bone fractures. And finally, reminding that mortality from hip fractures is much more higher in people with diabetes compared to people with normoglycemia. So we should work very careful because these people is very frail and need a lot of attention. And I hope I convince you that the bone fragility is a common complication in people with diabetes and they should be screened in the diabetes clinic. Thank you.
Could you also mention which oral anti-diabetic medications should we avoid and which ones we can use?
Oh, yes. This is a very important question. So in the diabetes clinic, we should start with metformin, that is very effective. And in terms of medication, GLP-1s are the best. And We have a lot of hope for tirzepatide because GIP has a specific receptor in the bone. So this medication may have a very positive effect on bone, but we don't have data yet. But GLP-1s are very safe and I believe have a good effect for bone health. DPP-4 inhibitors are totally neutral, as well as SGLT2 inhibitors. We may be more careful with the canagliflozin because of their data in a previous trial proving that people, mostly elderly, treated with canagliflozin had a higher risk of fractures. Then I would avoid use of sulfonylureas because they are independently associated to higher bone loss and to risk of fractures, likely because of the risk of hypoglycemia. And I would like to remind you also that we should be careful avoiding mostly in elderly people high doses of insulin. So we should try to de-intensify the treatment with insulin, lowering insulin dosage, keeping an A1C in elderly people maybe over 7.5. So they don't need a tight glucose control, that they should be always individualized. And in order to avoid that people with diabetes and treated with insulin have hypoglycemic events and the risk of falls. And of course, TZD should be avoided, at least in postmenopausal women and in elderly people. But the basic is lifestyle intervention. People should do physical exercise, mostly if they use a GLP-1 analog, because we suppose that with the weight loss, they may experience also muscle loss and maybe bone loss. So exercise is very important to balance the effect of weight loss and is strongly recommended in order to improve bone formation and to improve also osteoporosis.
You also mentioned your publications like underlying mechanisms. Could you also mention a little bit about that?
Yes, of course. And we basically studied the Wnt pathway, that is the biochemical pathway that regulates bone formation. And we found that at the bone level, there is a higher expression of genes that regulate bone formation. And in diabetes, these genes are down-regulated. So there is an increased expression of SOST, that is the gene that basically encodes for sclerostin. So we have a high sclerostin, lower RANX2, that is the final enzyme that basically induces also blastogenesis. We have a lower COL1A1, basically lower collagen. So these people have a high sclerostin, lower RANX2, lower collagen. But we found also that analyzing inflammation markers in the bone of people with diabetes or obesity, we found that there is a progressive increase in TNF-alpha between controls, obese patients that are intermediate, and finally with the highest level reached in people with diabetes. So convincing us that inflammation is another important risk factor. And again, people with diabetes have the highest levels of expression of TNF-alpha, and then obesity, and finally healthy controls. On the opposite, IL-10, that is an anti-inflammatory marker, is highly expressed in controls, is downregulated in both obese and diabetic people, meaning that people is more inflamed, and inflammation, of course, is an independent risk.
Thanks for joining us today. It was a pleasure to have Dr. Napoli with us today. Hope to see you in our next episode.